You're good to go.
Awesome. Thank you, Chantry. Hello, everyone. Thanks for having me. My name is Holly Weghorst. I'm a physician assistant at WVU Rheumatology. I've been practicing here for the last 17 years. Today, we're going to hit two quick topics on non-inflammatory joint pain that we all encounter pretty commonly, either osteoarthritis and fibromyalgia. And since we do have two topics, we're going to kind of just hit the high points through both topics. And we're just going to kind of go over the etiology, key clinical features, exam features, and how we're going to diagnose these things, and then priority treatments that we use and common treatments that we're going to find in both of these conditions. So let's start with osteoarthritis. It is probably the most common articular disorder that we find and one of the leading causes of disability. It's typically a slow progressive disease, and it really is a clinical diagnosis. So most of the time we don't need imaging and x-rays or labs to diagnose osteoarthritis in our patients. Key things that these patients are going to present with is they're going to complain of dull joint pain. It's typically going to get worse with activity when they're up and moving about. They're going to complain of stiffness. That stiffness is typically going to last less than 30 minutes for them to kind of get moving and get the best they're going to be for the day. They're also going to complain of this phenomenon called gelling, which is stiffness after immobility or rest. So a lot of times you'll have patients who, after a car ride or sitting and watching the news or things, and they try and get back up, they're going to have that gelling phenomenon present. And pain is typically going to be worse later in the afternoon or even early evening into nighttime, and sometimes keeps them from getting good rest. Risk factors or things that we think about that make osteoarthritis more common is increasing age. Sometimes family history, if they have a strong family history of arthritis. Obesity obviously can increase that risk for our larger joints and hips and knees. Previous injury or trauma to a joint can sometimes increase that risk of having arthritis in the joint as they get older. And if there's any abnormal joint mechanics from any other previous injuries or traumas that they have had, that may increase that joint likelihood of having arthritis. We're not really sure or understand the exact cause of osteoarthritis, but typically we think it's from repetitive trauma and then breakdown of that joint space and that cartilage in between. So because of that, we don't really have good treatments to modify the disease or prevent it. So most of our treatments are going to be on just symptomatic treatment, and we'll go through that in a bit. Progression, like I mentioned earlier, is typically slow. Symptoms can range from early stages and mild to moderate to severe. And then when it's severe, it really is going to limit their function and their ability to do their activities of daily living. And that how fast that worsens depends on some of the risk factors that I mentioned earlier. Do they have family history? Have they injured that joint? Are they obese? Those other factors that we think about. Patients also find that they can have temporary flares. Typically, we think about flare-ups in RA and psoriatic arthritis, but patients with osteoarthritis can sometimes have flares as well. And that can be environmental factors. A lot of times patients in the winter, when it's cold or it's damp, they'll find that their symptoms will worsen. And they may even have, they report swelling. And you may see some swelling, but it's certainly not going to be that swelling that we see in our inflammatory arthritides. And there may be some redness and tenderness, but again, it's not near as dramatic as we see in our inflammatory conditions. So these are the primary joints we typically see osteoarthritis in. And then obviously over to the right of our screen there is a picture of a pretty classic picture of osteoarthritis in the hands. Your DIPs, your PIPs, so those joints in the fingers are going to be very common to present with osteoarthritis. The base of the thumb, you're gonna notice it sometimes in the AC joint of the shoulder, so that acromioclavicular joint in the shoulder, hips, knees, the base of the toe, so bunion deformities, and then your facet joints in your cervical and lumbar spine. You can also see it in the wrist, elbows, and the true glenohumeral joint of the shoulder, ankles, and MCPs, but those sometimes are more from repetitive use or injury that you're going to see those, and that's where there are going to be secondary causes for that. So let's move on to sort of bang for a buck, the exam, right? This is a clinical diagnosis. So what are we going to be looking for when we're wanting to evaluate for osteoarthritis? Patients are coming and complaining of joint pain. So hands are where we're going to see it very commonly. Fingers, usually it's bilateral. It can or cannot be symmetric. Sometimes you'll find that if they're dominant in one hand, it may be worse in that hand compared to the other. Like I explained, and in this picture, you can see that their DIPs are heavily involved. Some of their PIPs, not as much as their DIPs. You can see a little bit of squaring at their CMCs. And so these changes that you see in the DIPs and PIPs are called Heberden's and Bouchard's. And these are more likely, almost 10 times more likely to be found in women than in men. So you'll see those changes more commonly and frequently on exam in women. And then as we go through the thumb, again, you're going to see this, what we call squaring, where you have the subluxation and adduction that gives the squared appearance of the CMC joint. And sometimes when you move that joint around, you're going to feel that crepitus or grinding sensation. You won't really feel that in the other fingers as much, but you will in the thumb. MCP, so the base of your fingers there, typically you're going to find changes more often with degenerative types of arthritis in the second and third MCPs, rather than the third and the fourth, where you'll see bony enlargement and thickening there. Another type of osteoarthritis that we do see is a more aggressive form or more severe form of osteoarthritis called erosive osteoarthritis. Again, it primarily involves the IP joints, specifically the distal IP joints. And on imaging, you're going to see very specific changes compared to just joint space narrowing. You're going to see almost what appears to be erosive changing. And a classic sign that we look for on that X-ray is something called gull winging, where there's central erosions on that X-ray that you're finding. And that's, again, more common that you see in women, and that can be hereditary as well. So this is a great schematic when we're comparing osteoarthritis to rheumatoid arthritis, and also the presentation and the patterns, right? So again, specific joints you're going to present more commonly for osteoarthritis than in rheumatoid arthritis. So for instance, we just went past the hand. You're going to see that the DIPs, or those distal joints, which we call Heberden's nodes, are going to be present in osteoarthritis. But when we think about rheumatoid, those joints are spared. So you're not going to find any joint damage or joint changes in the DIPs. The wrists, again, were a secondary place for osteoarthritis, so it's not going to be as common, but it's very commonly found in rheumatoid arthritis to have involvement. And the spine, typically in rheumatoid arthritis, the spine is spared. We only have one location in the cervical spine at that C12 joint that would have any possible involvement for rheumatoid arthritis. So when patients complain of pain in the spine, it's typically going to be more degenerative or mechanical in nature, and we'll go over that a little bit too. And this just sort of goes over the difference about stiffness. So osteoarthritis, morning stiffness is going to last longer, or not longer than 30 minutes. So it's not going to take them long to get going in the morning and feel the best that they're going to be. But for rheumatoid arthritis, that stiffness lasts way more than 30 minutes. It typically can be hours to midday before they feel like they're going to be loosened up. So this is just a sort of an idea that there are differences in patterns. So let's move on to the knee. This is the single most common lower limb disability in men and women over the age of 50. This X-ray sort of gives you a progression of how that joint damage looks. Typically, again, it's going to be maybe one side versus the other, worse in severity. Sometimes, again, a dominant leg or an injured leg may have worsening arthritis in that knee versus the other. We're going to find osteoarthritis in the knee more commonly in that patellofemoral joint or their medial tibiofemoral joint than the lateral joint there. On exam, you're going to find that maybe depending on the severity, they may have fixed flexion where they can't fully extend that leg. They may have a varus deformity. You're certainly going to probably feel crepitus when you move their knee. And they may even have quadricep weakness because they're not fully using that knee to keep that quadricep strong. And there may or may not be an effusion. So it's not uncommon for knee osteoarthritis, especially as it moves on in severity, to have an effusion present. And it not necessarily be inflammatory, but it just be the response from the arthritis itself. Moving on to the hip. So how a patient's going to present when they have hip pain. More often, it's going to be an aching and a stiffness, and they're going to say they feel restricted. They're going to present with that anterior groin pain. So this is important to think about when patients are complaining of hip pain. There's multiple components you think about when you think, oh, hip pain. So can it be bursitis? Can it be coming from their back or their sacroiliac joints or their true hip? And so true hip arthritis is typically going to present in the front of the hip or in the groin. They may complain that it radiates down into their thigh. Some patients may even have referred knee pain, and it could even radiate sometimes into the buttocks, depending on the severity. So knowing that where that is also will help tell you the location or the concern. They're going to have pain with active and passive range of motion. So any kind of range of motion is going to cause pain. And again, it's that sort of gelling phenomenon like we talked about. They're going to have pain when they first arise and they initially ambulate, and then they can kind of work it out a little bit and when they're up and moving. So let's kind of get into some the back pain. So mechanical versus inflammatory back pain. So mechanical back pain, you're going to think about that facet arthritis, degenerative disc disease, spondylosis, where they're going to have pain that's worse in the morning, and then when they're active, right, when they're up and moving or exercising, rotating, extending, they're going to complain about that pain, and then when they sit down and rest, they're going to feel better, right, and that pain isn't going to bother them as much. But when we think about inflammatory back pain, is that they're going to have stiffness and pain at rest, which is the opposite, right? So once they are up and moving, they're going to feel better, and they're not going to want to stop because they feel better. And this pain can sometimes wake them at night when it's inflammatory. So inflammatory back pain, we typically think about like ankylosing spondylitis or some of our seronegative arthritides, which can be psoriatic arthritis or inflammatory bowel-associated arthritis. So again, the nature and how it presents is very different, and that sort of helps us guide us to say, oh, this is more degenerative versus inflammatory in nature. And it may help you in your workup and what you need to pursue next in figuring that out. So evaluation, like I said earlier, it's a clinical diagnosis. We don't necessarily need blood work or x-rays to necessarily diagnose it. Certainly they're helpful. They can help us delineate the degree or involvement of that arthritis, right? Can we use non-pharmacologic and pharmacologic therapies to kind of help ease their pain and keep them active? Or do we need to think about getting them to physical therapy or a surgeon, depending on the extent of involvement? On our x-rays, we're going to find some joint space narrowing, as you saw in some of those x-rays on the screen earlier. You may see bone spurs or osteophytes that are present on the lateral sides of the joints. You may see subchondral sclerosis on the exam or on the imaging, and even cystic changes. And cystic changes can be hard because sometimes they may look like erosions, which is the changes that we're going to find in inflammatory types of arthritis, but they don't break the joint, the capsule of the bone, and you're not going to see those erosions on that X-ray. The labs that I listed here, the sedimentation rate, the rheumatoid factor, the CCP, which is a cyclic citrullonated peptide, and an ANA, aren't really all arthritis tests, and these aren't tests that you need to do for osteoarthritis, but they're going to be negative, right? We don't need these labs to diagnose osteoarthritis, and they're really not recommended to check when you are concerned about joint pain and patients are presenting to you with the first sign of joint pain, especially if you don't feel that this is an inflammatory process. It really can lead to a lot of false negatives, which then brings a lot of anxiety to patients. Thinking about ANAs is that 10 to 15% of the population has a positive ANA, and many of those, almost upwards of 90%, don't really have real inflammatory conditions. So it leads to unnecessary referrals and things. So not really first line labs that you think about doing initially when patients present for joint pain. Synovial fluid is not necessary to diagnose osteoarthritis. However, it's helpful if you do have a swollen knee to rule out infection, or even some of our crystalline arthropathies, which I think was presented earlier already with Dr. Scuro, or even our rheumatoid types of arthritis. Typically in your synovial fluid, you're not going to find it to be inflammatory. You're going to have less than 2,000 white blood cells, and it's predominantly going to be mononuclear cells in characteristic. So let's talk about how we manage osteoarthritis. A lot of it is just talking to the patients and having them understand osteoarthritis. How do you get it? What are risk factors? Did they injure that joint previously? And what's the expected prognosis? How does this sort of progress through their lifespan, and what are they to expect, right? Ultimately, you're wanting to explain to them what's the goals of managing this pain, right? We want to minimize pain, right? That's a lot of what keeps people immobile, and how we optimize that function, and trying to modify any joint damage that we can. And some of those risk factors, such as obesity and things like that. More often than not, you're going to need to use non-pharmacologic and pharmacologic treatments to help keep the patients moving, and preventing them from, disability or even potentially surgeries, right? So when we're thinking about how do we help them without having to go straight towards medicines, because certainly there's risks involved with that. And sometimes not all of our older patients aren't always great candidates for some of our pharmacologic options. If we can reduce weight, right, any weight reduction, at least 10% in their body weight can decrease their pain by 50%. So it's pretty significant. And if they know that, that may give them incentive to lose that weight. Physical therapy and exercise are always a great opportunity, even if you can give them home exercises, if going to formal physical therapy isn't a feasible option for them for travel or cost. Acupuncture, I've had a great number of patients who have found that acupuncture has been very beneficial for them. Heat therapy, most patients with arthritis will tell you that they like heat or prefer heat to help their joints. And again, this is temporary. And then, of course, depending on the severity of the arthritis and how it limits their ability, sometimes braces or assistive devices can be very helpful to help support that joint moving forward. And then obviously we have pharmacologic options and surgical evaluation and treatment. And I certainly am not going to go into surgical evaluation and treatment, but let's talk about some of those pharmacologic options. So typically our first line treatments are going to be topical oral NSAIDs, right? Ibuprofen, Aleve, those sorts of things. We can also consider topicals, and there are several over-the-counter topical NSAIDs that patients more often than not will find great benefit if they use it correctly. And it does have a lot lower risks than the oral NSAIDs, especially for patients who have known heart disease or chronic kidney disease or stomach ulcers or bleeding ulcers that really aren't great candidates for our oral NSAIDs. These topicals are a great alternative for them to use. Oral NSAIDs are really the preferred when we start thinking about, more than just a few joints or hip osteoarthritis. But again, it becomes difficult with maybe some of the comorbidities that our older population may have. We certainly always want to use the lowest effective dose and try and use it as needed. Most of our patients are going to say their arthritis just comes and goes. It's going to be pretty consistent day to day. It just may be whether that pain inhibits their activity day to day, right? But trying to have them gauge, well, is that pain bad enough today that you feel like you need to take something, or can you manage through with other supportive measures like non-pharmacologic options to prevent those risks of NSAIDs that we all know about. Another opportunity we have for medicine choices is duloxetine or Cymbalta. It has been FDA approved to help treat osteoarthritis pain. It is a great alternative for patients who can't use NSAIDs, and especially for some of our patients with larger joint arthritis, it can be pretty great. So again, if they don't have a contraindication, it's a great alternative to have in your back pocket when NSAIDs fail or are contraindicated. Topical capsaicin is, again, has a limited use. It can be helpful. Obviously, there are risks with using it and making sure that patients understand how they use it appropriately. But there are many over-the-counter topical options. And sometimes it's just trial and error for many patients for them to try and find a topical cream or gel that they find is helpful. And if it is, then you just, have them continue to use it. Obviously, once some of our medication options have failed or they're not getting the results that we want, we can always move on to an intra-articular glucocorticoid injection, Obviously, these are limited. They're not, they have a short duration of effect. They're not perfect. Some patients may only get a few weeks benefit. Some may get several months benefit. Sometimes it can prolong the need for surgery if we're trying to prevent that pathway. But we also know that sometimes repetitive injections may accelerate OA progression. So it may push that severity of arthritis forward and maybe the need for surgical intervention sooner rather than later. Many patients will use acetaminophen or Tylenol, and we have to think about its risks too. Obviously, the biggest is liver risk, and making sure that they understand the maximum dose in a day, and that we're not exceeding those 3,000 milligrams in 24 hours, so reduce that liver risk. But most often patients don't find that they're going to get the clinical effects of that arthritis pain like they do with those NSAIDs. So it's sort of marginal compared to our NSAID use. We certainly don't recommend opioids on a regular basis. That's sort of reserved for severe end-stage cases where patients don't really have other options. And if you're not comfortable yourself, referring them to pain management would be the next best step. Not typically do we recommend supplements, but some patients will use them and they will say that they find benefit. Obviously, you have to think about the other risks with supplements that we don't know all of the risks for, and there are other medical conditions. Common ones are glucosamine and chondroitin. Fish oil are ones that you see and find about commonly. Curcumin or turmeric may have some benefits. It's another supplement that is commonly used as a natural anti-inflammatory. Again, we have to be cautious when using this, and more specifically with some of our patients who are on blood thinners, because again, it has that anti-inflammatory property similar to our NSAIDs. Those risks could be similar. So when patients are using those and they are on blood thinners, just ask them to proceed with caution. So that's the quick osteoarthritis. We'll kind of jump into fibromyalgia here a little more. So as we talked about earlier, this is non-inflammatory talk, right? So fibromyalgia is a chronic, non-inflammatory, non-autoimmune, widespread pain syndrome that interferes with their daily activity. It is a centralized pain syndrome, a chronic centralized pain syndrome. What research currently suggests is that it's really more a disorder of pain regulation, and that it's more a form of central sensitization or nociplastic pain. Fibromyalgia can exist as a primary diagnosis or secondary, and we'll go over some of those other secondaries causes in a minute. It is found in about 3 to 6% of the population, with majority of these being our female population, about ages 30 to 55. Sometimes we find that fibromyalgia can onset after traumas, infections, cancers, or arthritis, but this isn't as common as you would think, that fibromyalgia starts after those incidents. And secondary causes of fibromyalgia, it's probably about 20% of our RA patients, lupus and psoriatic arthritis patients will also have coexisting fibromyalgia, and about 10% in our ankylosing spondylitis patients. So it can present in rheumatologic conditions, but again, it isn't a primary cause, and having a rheumatologic condition doesn't mean that you're going to have fibromyalgia either. So how do these patients present to you? So again, I mentioned earlier chronic, and in this case, that means greater than 3 months. It is non-inflammatory, so you're not going to find elevated inflammatory markers. You're not going to find inflammation in your joints, and it's not an autoimmune disorder. They're going to come to complaining to you of widespread pain, fatigue, stiffness. They're going to have some sort of sleep disturbance that they just can't wake up rested. They're going to complain of cognitive problems, and a lot of them will say it's a brain fog, or patients call it fibro fog. And they may have a coexisting mood disorder, such as depression or anxiety, and maybe both. Your physical exam's really not going to reveal any specific findings. Again, it's non-inflammatory, so you're not going to maybe see that swelling or that joint deformity like you did with osteoarthritis on that exam. Tender points used to be thought as part of that exam to help sort of diagnose and treat fibromyalgia, but really those are no longer part of the diagnostic criteria. They're not sensitive or specific enough to be used. They can change day to day, and so they're no longer really recommended when you're thinking about a fibromyalgia diagnosis. There are 2 different proposed criteria present. There's the 2010 ACR criteria and the 2019 AAPT criteria. These really haven't been validated to use as clinical diagnosis, but they are helpful when you're thinking about working through a patient, and do they meet some of that criteria and standards. If you have a difficult patient, you're not sure whether this could be something that they're dealing with or not. So secondary things or other conditions that can commonly present in patients with fibromyalgia, and these may be sort of red flags for you when you see patients who have these other coexisting diseases, and then they're complaining of widespread pain. Majority of patients with fibromyalgia are also going to have some sort of migraine or headache. Then there may maybe complain of irritable bowel syndrome. They're going to complain of restless leg, which is that sleep disturbance that we talked about. They may have symptoms of interstitial cystitis. They may have primary dysmenorrhea or chronic pelvic pain syndromes. They may have chronic TMJ disorders. And some of them may even have like hypersensitivity or multiple chemical sensitivity syndromes. Those patients that you see have, their allergy list is quite extensive. So let's dive into some of those features a little more. Obviously, one of the first things we think about is widespread pain. So their pain is going to sort of not really have a pattern. It's going to be variable. The quality is going to change. How intense it's going to be is going to be variable. And it doesn't really have a pattern that you would think, oh, this is a neurologic problem or just a arthritic problem. It's going to have a prominent myalgia component. So they're going to also not only complain of joint pain, but they're going to complain of a lot of muscle pain. And with the joint pain, sometimes patients will say that they feel swelling, that their joints feel swollen or they feel stiff. But when on exam, you're not really going to see any of that objective swelling like you may see in osteoarthritis or rheumatoid arthritis. And they're tending to have a lot higher levels of musculoskeletal pain than maybe what you can find on exam, which then ultimately leads to greater impairment or function through their day, but yet you don't really have a reason why they shouldn't be able to move their knee, right? Or move their hip or bend over because their back is bothering them so much. Many patients will describe this as they hurt all over. I've had plenty of patients tell me, I feel like I have the flu, or I'm one big bruise, or I feel like I got hit by a bus, if we could imagine how that felt. And they may even describe numbness and tingling and burning. Most often this pain is going to be pretty consistent. It can wax and wane and maybe have a better day or a good day in comparison, but that pain doesn't normally go away. And more often than not, we talk about that, 3 months is how long they've had to have that pain, but more often patients are going to have that pain much longer than 3 months to be present, and they complained about it before we really recognize. So fatigue, and how does that present? More often our patients are going to have fatigue where they have this just overwhelming sense of exhaustion. They're going to feel weak. They don't feel like they can exercise, or they're exercise intolerant. They're going to have this mental exhaustion. The fatigue, again, seems to be really out of proportion to the amount of effort or the amount of rest or the amount of sleep that they report. And there's going to be some amount of sleep disturbance. Obviously, sometimes work schedules alter our sleep disturbance. Significant other partners' sleep schedule can create sleep disturbances. Young children or animals, right, alter our sleep at night. But for them, even if they get 8 hours of sleep, they still never wake up rested. So somehow that they're not getting that restorative sleep, and so we call that non-restorative sleep, and then their symptoms are significantly increased. There certainly have been many studies that show sleep disorders or non-restorative sleep can mock or mimic those fibromyalgia symptoms, and really it's probably maybe more sleep disorder than a true fibromyalgia. So anytime you have a patient with sort of sleep issues, these are one of the pathways you want to think about is looking into their sleep first, because you may improve a lot by just improving their sleep. So mood disorders, again, we talked about depression and anxiety can be a very commonly presented comorbidity in fibromyalgia. Up to 30 to 50% of our patients. Many of those patients already who have mood disorders already experience some of these other symptoms of fibromyalgia, where they may have sleep disturbances and they may have fatigue and they may have some level of pain. It's interesting, though, that patients with bipolar or PTSD can more commonly have fibromyalgia than the general population. So just something to take note. And, again, and how does our brain perceive that pain, that central pain mechanism like we talked about. Um, Coming back to that is how they feel like they have a cognitive impairment, and they complain of disturbances, and that they have this brain fog or fibro fog. And patients will say they feel like they're thinking, through mud, or they're slow to respond, or they find that they don't have that memory piece like they used to, or things that they used to do seem harder than before. And on actual memory testing or cognitive testing, it seems to be more subjective type symptoms than true objective findings. Again, like I alluded to with the exam, it's more subjective that they're having this swelling, but they're really not true swelling on that exam. So moving on to sort of neurologic features that may present in fibromyalgia, we talked about how a great majority of these patients will have a headache. Like over half can have some variation of headache or migraine. They may complain of neuropathic type symptoms like paresthesias, right? So they're going to have all of these symptoms that make it sound like it's some sort of neuropathy, but really the exam is pretty unremarkable. More often than not, when you send them for an EMG, they're not going to really find any specific changes. And on here, I obviously list that there can sometimes be a small fibroneuropathy that you're going to find on a skin biopsy, but this isn't part of that routine diagnosis. And this is something that we would rely on our neurologic colleagues to sort of really pursue whether they felt that was necessary. So this isn't part of that criteria or something that we think about. It just can't be found. Some of our patients can also have autonomic nervous system changes, where they're having those orthostatic hypotension episodes or altered heart rate and things like that. So that's another thing that can commonly present in our patients with fibromyalgia. So moving on to how we evaluate and diagnose and when we're concerned. Again, it's a clinical diagnosis, just as it was for osteoarthritis. And unfortunately, it's sort of clinical diagnosis based on the fact that it's not explained by another condition. And sometimes when you say that to patients or you think about it, they're sort of saying, well, you're making it up. And that's not true. It just makes it harder for them to understand, because we don't have those confirmatory labs and imaging or exam findings that kind of really solidify the diagnosis. You really have to have these red flags when your suspicion for fibromyalgia is increased, when they're having this out of proportion musculoskeletal pain from their exam or imaging, or the fatigue is out of proportion to what they're telling you, or the neurologic exam is benign, but they're complaining of all of these neurologic symptoms. And then also it's increased even further if they have some of those other comorbid conditions like we talked about with irritable bowel or interstitial cystitis symptoms or TMJ or headaches. And so really, when we're evaluating these patients, the exam and the labs and the x-rays are just more helpful in ruling things out than ruling fibromyalgia in. And so typical labs that you may use when you're initially working up and evaluating for fibromyalgia are blood count, so making sure the patients aren't anemic or have any neutropenias, a CMP, making sure there's not any electrolyte imbalances or kidney disease present. It is appropriate to check a SED rate and a CRP. These labs are going to be normal in these patients. A thyroid, we know that thyroid can present with many of these symptoms as well. Vitamin D and vitamin B12, making sure that those are normal and replacing those appropriately, and if they're iron deficient. So these are the basic things that you want to check. Again, just like with the osteoarthritis presentation, ANAs, rheumatoid factors, CCPs really shouldn't be first line labs that you check unless you have a high suspicion based on their exam or your discussion with the patient that you think there really is something inflammatory going on. So not your first labs that you're going to go to. So how do we treat patients with fibromyalgia? Again, it's very similar to osteoarthritis. We're going to individualize treatment with both pharmacologic and non-pharmacologic treatment options. It's really important to have discussions with patients about what the signs, symptoms, how their course looks, what the prognosis is, what the expectations of their treatment is, and making it realistic. And that, we may not be able to get rid of all of that pain, but getting their pain controlled well enough that they can still function and do their activities of daily living. Just as it is in osteoarthritis, it's really more symptomatic relief that we're looking for with treatment, and discussing all of these things with these patients and considering also, do they have any of these comorbid conditions, and are we effectively treating those comorbid conditions well? And if not, how do we improve those? Sometimes just improving those makes fibromyalgia treatment a lot more successful. And what are those barriers for those patients? Many times, patients are on multiple medications. Reviewing, are some of the medications worsening or contributing to some of the fatigue and other side effects that could worsen fibromyalgia, and reviewing that with those patients. So a lot of times for fibromyalgia, it's time and taking a lot of time and reviewing medicines and results, and explaining these symptoms to patients rather than just a quick refill of a medicine. So non-pharmacologic things that we think about, patient education is key. And one of the first things we really need to focus on with patients, and making sure that they understand. Cognitive therapies are always a great option. Not everybody's always open to CBT, but always a great opportunity. Mindfulness, meditation are all great. Again, sometimes it's hard to get buy-in for certain patients. And the other thing that really is important for these patients is increasing their activity and exercise. And it's hard because many patients will say exercise or activity makes them feel worse. So again, getting that buy-in. So trying to find a program that you think is going to be beneficial to them, making sure that they're pacing themselves, that it's going to be low impact, and then they can build off of that. Other things to think about, nutrition and dietary things that may be contributing. Acupuncture has been great, and dry needling has been a great opportunity for patients with fibromyalgia, just like it was in osteoarthritis. There has been some idea that trigger or tender points can be helpful. Massage therapy, again, this is a hit or miss. Some patients appreciate massage therapy. Others say it's too painful and it makes them feel worse. So not always great for every patient. And chiropractic, again, right patient population, depending on their other risks. So thinking about medication options, right? Really, medicines are only going to maybe give you a modestly effective benefit. So again, while we said earlier, using both non-pharmacologic and pharmacologic options, and then also making sure that all their other comorbid conditions are well controlled and well managed. And then when we normally think about where do we want to start with patients and thinking about what that initial agent should be, is mostly going to be based on their symptoms and what their biggest complaint is, and then also their comorbid conditions and whether those things are safe. As any medicine we do anytime is starting at the lowest dose and increasing, for the best benefit. Similar to osteoarthritis, we really don't recommend opioids. Steroids, NSAIDs can be sometimes helpful, but really they haven't been found to be helpful or effective. And then our benzos and our non-benzos really haven't been found to be effective. Patients may say with the corticosteroids that initially they feel good, that may help their fatigue and they get a little boost of energy, but the long-term effectiveness really kind of putters out. And we all know that long-term corticosteroid use isn't really the best treatment. So avoiding that and giving that, unless again, you think there's an underlying inflammatory component. So these are some of our common medicines or oral medications that we'll use in patients with fibromyalgia. We think about amitriptyline or Flexeril, cyclobenzaprine when patients are having more widespread pain or even sleep disturbances. Others common ones that you can sometimes use outside of amitriptyline is trazodone or nortriptyline at bedtime. When they have fatigue and or depression, then you can kind of get great benefit out of Cymbalta or Savella in these patients. Again, being cautious if they already are on other SSRIs or SNRIs for their mood. And then again, working on their sleep, right? How prominent sleep disturbances. So again, they have sleep disturbances that you need to get a sleep physician or sleep team involved. And if not, thinking about maybe Lyrica or gabapentin, and again, starting at a lowest effective dose and increasing as they tolerate. So when to think about referring these patients on, initially the workups and the management is best with the primary care, because you're going to be able to see them a lot easier, make those changes, and you can adjust those medications appropriately based on some of their other comorbid conditions that you're also probably already managing in your office. Rheumatology can be consulted really if there's really a lot of uncertainty, right? If you're like, they're just not responding to medicines as I would expect, and or there's these other pieces that just don't really make sense, then we can kind of come in and certainly help rule in or rule out, if there is a possible underlying inflammatory autoimmune process or not. And then you think about those other subspecialty referrals, like the neurology teams and your sleep teams. And then your psychiatrists and your counselors, and helping treat all those other comorbid conditions, so that those are all kind of tucked away neatly, which is going to ultimately lead to better outcomes for that patient. So these are my references. And I thank everybody for listening. That was sort of a crash course for osteoarthritis and fibromyalgia, but hopefully it was sort of the high points that you may find on your day-to-day, and moving forward to help these patients out.